Hello, everyone. Thank you so much for calling in tonight. We're very excited to have Dr. Rachel Rosovsky with us, as well as a patient named Mark, who is here to share his story. Today, Dr. Rosovsky will be talking about the importance of follow-up care. Throughout the presentation, if you have any questions, you can send them to me right over using the questions bar. And we will be happy to answer questions in the last about 30 to 20 minutes of the program. I'll now hand it over to Dr. Rachel Rosovsky. Thank you, Dr. Rosovsky, for being with us.
Oh, thank you. It's a real pleasure to be here, and I'm particularly excited because one of my patients is actually joining me to do this webinar tonight. So it'll be really wonderful to hear from him halfway through it too. As Molly said, I'm going to be speaking about, after a clot, the importance of follow-up care. Okay, let's see. Oh, here we go. So I get research support from Janssen and Bristol Myers Squibb, and I'm a consultant for Bayer, and Mark told me he had no disclosures. So this is the agenda. Thought we would speak first, just the scope of the problem very quickly, which I think you're probably all aware of. Briefly talk about the pulmonary embolus response team. I know you had a webinar on it in the past, and really I want to spend the bulk of our time talking about the importance of follow-up care. Further workup that needs to be done, trying to figure out maybe the etiology of the clot, screening for potentially long-term complications of PEs, and then further treatment if you have an IVC filter in place, and of course what anticoagulant you're on and how that's going to be managed. So I thought I would start with a case, and I have permission to use this. This is a 48-year-old gentleman who presented to a local hospital with acute shortness of breath. And he had a CT, which you can see here, and he had clots on both sides of his lung, and what's called his RV-LV ratio, which is the right ventricle size to the left ventricle size, was greater than 1. And that indicates that he was stressing his heart. He was given 1 dose of enoxaparin, which is a type of low molecular weight heparin, and he was sent to our hospital. When he got to Mass General, he was working pretty hard. His saturations were 87% on room air, so normal should be around the mid-90s, and he was requiring 15 liters of oxygen through the nose, which is very high. His heart rate was elevated, so he was what's called tachycardic, and his respiratory rate, he was breathing many times a minute. And fortunately, his blood pressure was okay. He had what's called an echocardiogram, which is an ultrasound of his heart, and it showed that his right side of his heart, his right ventricle, was quite dilated, and it wasn't moving very well, which is hypokinetic, and his pressures were quite high. So again, indicating that he was injuring his heart. And to further support that, he had elevated troponin and something called BNP, which are markers that the heart can release when it's being injured. So just briefly, the scope of the problem, which I think you're all aware of. So this is an astonishing statistic that was released by World Thrombosis Day in October. And 1 in 4 people worldwide will die of some condition caused by thrombosis. And it's actually the leading cause of global death and disability. That's unbelievable. And in the United States, it's the 3rd leading cause of cardiovascular death, with 2 million deep vein thrombosis, 600,000 PEs, and 60,000 deaths. And the estimated cost of venous thromboembolism care is over $1.5 billion a year. And this problem is not going away. As you can see on this graph, the incidence is increasing. People are getting older, so age is a risk factor. Obesity continues to be a problem, another risk factor, and cancer is on the rise, a 3rd risk factor. I think another really important piece of information to know about blood clots is that nobody is immune, from the youngest to the oldest to the most out of shape to Serena Williams, arguably probably the fittest female athlete or one of them in the world, who actually got a blood clot after an airplane ride. And you can actually look through history and see very fit people like Jerome Kersey, who was an NBA star, who died after having a knee surgery, or Chris Bosh, who a few days before the All-Star game in February of 2016, he woke with a sore calf. He was found to have a recurrent blood clot, and his career was over. So why do we even worry about pulmonary embolism? Well, it can be fatal within 1 hour after the onset of symptoms in about 10% of cases. And untreated mortality is as high as 30%. So just to take a step back so that you understand kind of the different types of PE. So probably the most worrisome is massive PE. Those are people who have a low blood pressure, hypotension, and they're in shock. The next category is submassive. These patients, their blood pressure is fine, it's normal, but they have signs or symptoms that show they're straining their heart, like our patient. So they might have right ventricular strain either on their echocardiogram, on their CAT scan, or through lab work. And then neither massive nor submassive, that's considered low risk. And the good news is that most of the patients fall into the category of low risk and submassive, and that mortality rate is pretty low. However, in patients that have the massive PE, those are the ones that are in shock, have low blood pressure. This was a large registry study of patients that showed at 3 months, the mortality rate was over 50%. So the good news is that over the last number of years, there's been a number of new techniques and new therapies to treat pulmonary embolism. But the problem is there's so many, and there's not really a lot of great guidelines on how to decide which one to pick for which patient. So you can do anticoagulation alone. Maybe you want to do something called catheter-directed thrombolysis, where you put catheters up through the groin and infuse a clot buster right into the clot. Some people who cannot maintain their blood pressure are in shock. We put them almost on like this thing called ECMO, which is like a heart-lung machine. There's suction embolectomy, where you can suck the clot out, or even surgery, where you can actually surgically remove it. So there's all these options, and it's hard to know how do you decide which one to do for which patient. And because of this lack of guidelines, this is really the impetus for starting the Pulmonary Embolus Response Team, which you've already heard about and had a whole webinar. But essentially, it was a group of physicians actually started at MGH, where we realized when patients came in with a PE that there was really no one kind of algorithm or way to treat them, and kind of how they were treated depended on where they were in the hospital. So we formed the Pulmonary Embolus Response Team, which is really to a group of experts who come together in real time, expeditiously and simultaneously, to coordinate the care of somebody who presents with an acute PE, and really to try and figure out what the most appropriate therapeutic option is for each patient. And so going back to our patient, actually the PERT team was called on this patient, and our vascular fellow went down to evaluate the patient and realized he was pretty sick, and immediately called a PERT meeting where about 10 different specialists got on an online meeting, and right then and there discussed his case. And we first classified him as submassive because he had the strain on his heart, the elevated troponin, and he was tachycardic, meaning his heart rate was very high. He had a large clot burden, and his RV wasn't working, and he was hypoxic, meaning his oxygen level was low. So we actually decided, weighing all the risks and benefits, to proceed with this catheter-directed thrombectomy and lysis. And this is a photo courtesy of Ken Rosenfield, who actually did the procedure on this patient. And you can see how many people are involved in care. Anesthesia, you have CT surgery as backup, nursing, perfusion, echocardiogram, vascular medicine. One of the things we realized when we started this a few years after we started it is that these patients were getting unbelievable, kind of a rich multidisciplinary experience when they were in the hospital. But we had no way of figuring out who was following up with them when they got discharged, and whether there was any kind of way to make sure that people were getting the same quality care in their follow-up. And that was really the impetus behind starting the follow-up clinic, at least for PERT. So you may be saying to yourself, well, my hospital didn't have a PERT, I don't even know what a PERT is, and does this mean that I'm not going to get good care? Well, absolutely not. Really, the most important thing is that you go to a follow-up clinic after you have a PE, and it can be something like a PERT. We actually have another follow-up clinic, our outpatient DVT PE follow-up clinic. When people come to our emergency room and have a low-risk PE or DVT, instead of being admitted, they actually go to our ED observation unit and come into a follow-up clinic within a week, either in our hematology clinic or our vascular medicine. And I think the important thing is that every clinic is different. One size does not fit all, and really the clinic that you might go to really might depend on the needs and resources of that hospital, or community center that you're going to. So the structure of the two clinics I mentioned is we have a multidisciplinary follow-up clinic. And so in that clinic, we actually have pulmonary, cardiology, and hematology who come to the clinic twice a month. And we talk about all of the patients for an hour before the clinic begins. And we go through every single patient and what happened and what we think their short and long-term follow-up care should be. Our outpatient DVT clinic's a little bit different. It's just manned by one person, so either hematology or vascular, and we usually see that person within a week after their clot. So I want to spend the majority of the time we have left before questions really talking about follow-up care and what needs to happen during that. Specifically reviewing the clinical course of what happened to each of you, further workup, meaning inquiring into the etiology of the PE, why did you get it? Age-appropriate cancer screening, the utility of a hypercoagulable workup, if there's any abnormal findings, either on the labs, physical exam, or history, screening for long-term complications, and then briefly talking about further treatment, IVC filters, and obviously anticoagulation. I think the first thing, review clinical course. So when patients come into our follow-up clinic, the first thing I do is ask them what they remember from their time, because oftentimes people are so sick and overwhelmed and they really don't remember who they saw, what happened to them, how they were treated. So really to kind of start there and explain what did happen is very helpful to a lot of patients. Once we do that, we focus on further workup. And I would say probably the first question most of my patients ask is, why did I get the blood clot? And so thinking about workup to figure that out, one of the things is that when patients present with blood clots, there's kind of two categories of them. One is the blood clot was provoked, meaning you can identify what caused the blood clot. So that would be somebody who maybe fractured a leg, was in a cast, or maybe had surgery, or was pregnant, or was on hormones. Those are provoking factors. Those can cause a blood clot. The other category is unprovoked, meaning we don't know why that person got a blood clot. And we do know that in patients that present with unprovoked blood clots, that if we follow those people for 1 or 2 years, we'll actually find a hidden cancer in about 5 to maybe 10% of patients. Now, oftentimes when I tell this to patients, they freak out a little bit, but 5 to 10% means that 90 to 95% of patients do not have this. And so what's important when you do have a blood clot is to make sure that you are up to date with what's called age-appropriate cancer screening. So for women, that would be a pap smear. If they're over the age of 40, that would be a mammogram, and over the age of 50, it would be a colonoscopy. For men, that would be a prostate, a PSA, which is called a prostate-specific antigen, which is a blood test, and a colonoscopy over the age of 50. Recently, in patients that are smokers, there is some data to suggest, actually that is pretty definitive, that a low-dose CAT scan can save lives. So in patients that have a certain number of years of smoking, should talk with their doctors about whether or not that is appropriate. So the other thing to think about when thinking about workup is screening for a hypercoagulable state. And there are 5 inherited hypercoagulable states, and you might be familiar with these. I've listed them here. Factor V Leiden, one called prothrombin gene mutation, protein C deficiency, protein S deficiency, and antithrombin 3 deficiency. And all of these act in the clotting cascade in your body. And there's actually some, the prevalence of these and how frequently you see them in the general population, as you can see here, is pretty uncommon. So antithrombin 3 deficiency, very uncommon, protein C deficiency, and in fact, protein S is so uncommon, it's not even, it's unknown how frequent it is. The 2 most common ones are factor V Leiden and the prothrombin gene mutation. And so recommendations to whether or not we should proceed with routine hypercoagulable testing are actually pretty controversial, and there's no validated testing guidelines that have been published, even though we know that patients with inherited thrombophilia are recognized to increase the risk of their first VTE. And Molly did tell me that you had a webinar about this, so I'm not going to go into great detail, except for I think it's really important when you do have your follow-up visits with your provider that you actually ask about this. And really, when thinking about whether or not to test somebody for these conditions, you have to ask three questions. Why are you testing? And will the results actually impact or change the management? Or will the results cause harm? And there's kind of two situations to even think about testing. The first one is called secondary prevention. So that's for people that have already had a blood clot. So they've already had a blood clot. And whether or not the testing is going to provide any guidance in terms of duration of anticoagulation or type of anticoagulation. And then there's another scenario called primary prevention, and that's actually in your relatives. So would knowing whether or not you have an inherited risk factor help your relative in terms of preventing them from getting a blood clot? So those are the two scenarios. And really what we've learned is that for patients who have a provoked blood clot, we know what the risk factor is, that we don't need to do any of that testing. In patients who have an unprovoked blood clot or recurrent blood clots or blood clots in unusual situations or even a very strong family history, those are the times to consider testing and, again, talking with your doctor about that. There used to be recently, or actually more recently, there's been a number of organizations, including the American Society of Hematology and the Society for Vascular Medicine, where there's been a real push not to proceed with the testing. So, other things to think about working up is pursuing any abnormalities that you might see either on lab tests, in history, or physical exam. So, for example, I saw a patient recently who was seen in the hospital, and when I was talking to her, or actually when I was feeling her abdomen, her belly, I felt a very large mass. And so I ended up getting a CAT scan, and she had actually about a 12-centimeter mass. Fortunately, it turned out to be benign, but again, doing a very good history and physical exam and making sure that you tell your doctors if there's anything abnormal that you're feeling or experiencing. So going back to our patient, he did great. He was discharged home a few days later, despite being in the ICU, on one of those new oral anticoagulants, which we'll talk about a little bit later. In the hospital, his hematocrit was a little bit low. Actually, normal for a male would be 40/41, and he was 26. So he actually came to follow up, and I met him about a month after he was discharged. And I remember him saying, I feel great, doc. I haven't felt this great in so long. I feel great. And so we reviewed what happened to him in the hospital. We talked about what medication he was on. And then when it came to further workup, I said, you were anemic while you're in the hospital. Have you ever been told that? And he's like, well, maybe in the past, I don't remember. But so I said, well, we should probably repeat that. And so we did, and actually it was still very low. So because of that warranted a further workup, which I did. And in fact, the workup revealed that he had multiple myeloma. In case you don't know what this is, these are called serum-free kappa and lambda light chains and an M spike, which is an extra protein your body makes. And he ended up being diagnosed with multiple myeloma. And he recently had a bone marrow transplant and is doing very, very well. Now, when I bring up this case, one thing you might think about is, wow, should everybody who has a blood clot out of the blue be screened extensively for a hidden cancer? What if I had a blood clot out of the blue? Do I need to be screened for multiple myeloma? Well, there's actually been a lot of studies looking at this, number of studies. And I'm going to just briefly mention one study that was done in Canada where there were 845 patients, and they were randomized. They didn't get to choose to what was called limited cancer screening or limited cancer screening plus a CAT scan of their abdomen and pelvis. And the reason they came up with this study is that this author had actually collected about 15 other studies looking at limited versus extensive screening. And he found in those 15 studies that about 50% of people just with limited screening were discovered to have a cancer if they actually had one. They also found that when an abdominal or pelvic CT scan was done, that number increased to about 67%. So it still meant that about 30 cancers were not found, but adding that ABCT did increase it about a third. So that was the impetus behind this trial. And so half the people got the limited cancer screening, which was just kind of basic labs that you would normally get when you saw your doctor or workup for your clot, and then limited plus they added the CAT scan. And the primary outcome was looking at what cancers were missed initially by the screening and what cancers were found at 1 year follow-up. And in fact, very few, 4% had a new diagnosis of cancer. And when you looked at the limited versus the limited plus the CAT scan, there was really no difference. So this is what's called a p-value, and when it's significant, that means the p-value should be less than 0.05. So this is not significant. So really the same number of cancers were found at the initial screening, and in fact the same numbers were cancers were found 1 year later. That was missed by the limited screening and even missed by the screening plus the CT scan. So based on this, as well as a number of other studies, they've actually done a study looking at PET scans where half the people got PET scans and half of them didn't. They've done other studies where there's been extensive screening where people really got lots of different tests, and they never found, nothing has shown that there's any difference in mortality rate of the people that got extensive screening versus limited. So based on that, a number of guidelines have recommended that you do not extensively search for a hidden cancer. However, it is important that if you have any new symptom that is persistent or some abnormality, that you pursue workup for that. For example, going back to our case, our patient was anemic and was persistently anemic. So that certainly warranted a follow-up looking for that, which is what we did. And it's also incredibly important that you are up to date with your age-appropriate cancer screening, which we already talked about. And I cannot emphasize that enough because there are a number of people that have come into either one of my follow-up clinics, and I have found cancers just based on having them do their cancer screening. So if you are not up to date with your cancer screening, I encourage you to definitely do that. So we've talked about reviewing the clinical course. We've talked about further workup, inquiry into the etiology of your blood clot. What about screening for long-term complications? Well, you may be experiencing ongoing shortness of breath, and you are not alone. There's actually a new syndrome called post-pulmonary embolism syndrome that was recently described, and that is people have ongoing shortness of breath, even though they might be, 6 months or even a year out from their pulmonary embolism. And in fact, there was a study called the ELOPE study, which actually prospectively followed 100 people with PEs for a whole year. And they were asked quality of life questions. And they were also had what's called a 6-minute walk test, where they would walk and see how long it took them. And they did CAT scans of their chest and VQ scans. And they found, the investigators actually found that at 1 year, almost half of the people still had an impaired exercise capacity. And actually the number was about 46%. But what they found was that the things that were most significantly associated with that impaired exercise capacity was sex, age, the older people had worse, something called body mass index, which is related to how much you weigh, and smoking. And in fact, neither baseline nor residual clot was at all associated with impairment. So what this says is that actually it's almost the comorbidities with each patient that might contribute to that ongoing shortness of breath. Nevertheless, if you have ongoing shortness of breath, you should absolutely bring this up to your provider, because there is something called CTEPH, which is and I know you already actually had a whole lecture on this, as Molly told me recently, and that is CTEPH is chronic thromboembolic pulmonary hypertension. And it's pretty rare, and it's probably the most extreme when thinking about shortness of breath. But if you are having continued ongoing shortness of breath, there is a workup that should be performed. Usually an echocardiogram is done, which is that ultrasound which we did on our initial patient, to see whether or not you may be straining your heart. There's also something called a ventilation perfusion scan, which tells you how much oxygen is getting to each lobe of the lung and how much blood flow is going through, and seeing if there's kind of a difference between those two. And if those are abnormal, you should really go to a center that actually specializes in this complication. And if you do, they may do something more invasive, like what's called a pulmonary angiogram or even other things. So this is definitely a real phenomenon and something that you should absolutely bring up to your doctor if you do experience it. So how about further treatment? So in inferior vena cava filters, first of all, there's certain criteria for when you should actually place these in patients, usually in people that have a blood clot that cannot be, and that person cannot be anticoagulated safely. For example, let's say somebody has a small pulmonary embolism and maybe a blood clot in their legs, and they fell and they're bleeding into their head. Well, we probably can't put that person on a blood thinner for any time in the short term, and so that would be an indication to put what's called an inferior vena cava, and essentially that goes right into your vessel called the IVC, or inferior vena cava, which leads to your heart, and it's almost like a little basket, and it's put in. And so if there is a blood clot in the leg and you cannot be anticoagulated, if that blood clot breaks off, it would normally go to your lungs and could be quite dangerous, but that little basket catches it. The problem with the IVC filters is that they're put in and they're not always retrieved, and they can have complications associated with them. And in fact, a recent study found that 21% of these filters, which should be retrievable, were not retrieved because people were lost to follow-up or stopped their care, or maybe the physician forgot. So if you have an IVC filter, definitely bring it up with your patient, with your physician, because I think outpatient follow-up clinic can actually ensure that those people who have one during their acute illness have it removed when it's no longer indicated. So lastly, I just want to mention anticoagulation. So the questions to think about this are what type of anticoagulation you're on, how long do you need to be on this, does it need to be monitored, and actually what do you need to know about the drugs that you're taking. So there's a lot of different kinds of anticoagulants. The injectable ones, that's unfractionated heparin or low molecular heparin, you might enoxaparin or Lovenox or dalteparin or Fragment are the names you might be familiar with. There's also one called a synthetic pentasaccharide, which is fondaparinux or Rixtra. And then more recently, the oral ones, which is warfarin, which has been around for a long time, and then the new drugs, which are called the direct oral anticoagulants. And you've probably seen ads for all of these medications. One is called Pradaxa or dabigatran, and that's what's called a direct thrombin inhibitor. Just tells you where in the coagulation system it's stopping it. And then there are 4 factor 10A inhibitors, Xarelto or rivaroxaban is how you might know it, Eliquis or apixaban, Savasa or edoxaban, and then Vivexa or betrixaban. The last one is actually recently approved to treat patients who are at high risk of developing blood clots when they're in the hospital, and they're put on this, and then they stay on it for several days after they're released from the hospital. So that's not for the treatment of patients that have either a PE or a DVT. So when you're choosing an anticoagulant, there's a number of things to think about. The first one are, what are the patient-related factors? What are your comorbidities? What is your bleeding risk? What is your ability to remember to take this? Because some of them are once a day, some of them are twice a day, some you have to take with food, some you don't. Some have to start with a shot for the first week or two. What is your preference, and what is your weight? Because not all of these blood thinners have been extensively evaluated in patients over 120 kilograms. So that's something to think about if that is your weight. There's also medication-related factors. What other medications are you on? Meaning potential drug and drug interactions. It's really important, and you should always ask your doctor and or pharmacist before you start any new medication to see if there is any interaction with the new one and the ones you're taking. Are there any interventions or procedures that are being planned? Well, if there are, you probably need to be on a blood thinner that's short-acting and potentially reversible. And one of the most important factors that I have come to realize is what your insurance covers, because some of these are incredibly expensive and some are not. There are some programs that some of the drug companies provide drug, and so you can work with your doctor to figure that out. In terms of the new drugs, those new direct oral anticoagulants that I just showed you, there are no what's called head-to-head trials. They weren't compared to each other, so we don't know if one is better than the other. They were all compared to warfarin, and they were all found to be the same in terms of preventing recurrent blood clots, and many of them actually did better in terms of risk of bleeding. There are a few key differences, and this is a recent article I wrote just looking at all of them. And the reason I put this up is whichever one you're on, make sure you understand what the dose is, because many of them start with a pill twice a day and go to once a day, maybe start a higher dose and then go at a lower dose. Some of them start with something like an injectable, like that enoxaparin or Lovenox or Fragmin or dalteparin, and then go to the oral one. So it's important you know what you're taking and what the exact dose is, because it is complicated. So the next thing is, how long do you need to be on your blood thinner? And this really has to do with what is your risk of having another blood clot. If your risk is low, you probably don't need to stay on the blood thinner for long term, and if the risk is high, you probably do. So if your blood clot was provoked by a surgery, your risk of having another blood clot at 1 in 5 years is pretty low. 1% at 1 year, 3% at 5 years. If it's provoked by a non-surgical but reversible risk, it's a little bit higher. And if it's an unprovoked blood clot, meaning we didn't figure out why you got the blood clot, that 1 year risk is 10%, and that 5 year risk is up to 30%. And if it's a cancer-associated blood clot, that 1 year risk is 15%, and we actually don't know what the 5 year risk is because a lot of these patients will pass away from their cancer. So going back to the patients that had a blood clot out of the blue, or that unprovoked or idiopathic blood clot, there are many prediction models, and I just put one up here to show you that at 5 years the risk is 25 to 30%, and it actually increases with time. This is really important when thinking about, do I need to stay on the blood thinner for 3 months, 6 months, or is this something I need long term? And it really, again, boils down to what is your risk of having another blood clot. So deciding who should stay on it really depends on 3 factors. Number 1, what is your bleeding risk? Number 2, what is your thrombotic risk, what we just talked about, your recurrent clot risk? And actually, what are your values and preferences? I certainly have young people that come in and say, oh my God, I don't want to be on blood thinner the rest of my life. Are you kidding? I want to go skiing. I want to do all of this stuff. And so you really have to sit down with your doctor and talk about these things to come up with the best treatment plan for you. We do know that there are some patients that are more likely to benefit from longer term. Those, again, are people that I just showed you with the blood clots out of the blue, because that recurrent risk is so high. We know patients with active cancer are at a very high risk of recurrent clots. People that have something, we didn't really talk about this, but antiphospholipid syndrome, an extra protein that you may have acquired that puts you at a high risk. Definitely, if this is not your first blood clot, you're at a very high risk of having another one. And then there's a category that we don't really know. Maybe you will benefit, but maybe we don't. You won't. We don't have a lot of great data, but I will show you some. Those are in patients that might have a provoked blood clot, but maybe have persistent risk factors. So if we know why you got the blood clot and you still have that risk factor, chances are you're going to get another blood clot unless you get rid of that risk factor or stay on a blood thinner. Or if it's an unprovoked distal clot, but with persistent risk factors, or if it's an unprovoked kind of incidental clot. We do know that there are a number of features that are associated with a higher rate of recurrence, and that is patients that are obese, patients that have potentially residual clot, patients that might have more than one hypercoagulable state, and then sometimes in patients have an elevated what's called D-dimer, which is a marker of clotting. So in thinking about not only the duration, how long you need to be on the blood thinner, what is the dose you should be on? So I already showed you that all 4 of those new direct oral anticoagulants have different doses. On top of that, 2 of the studies, one involving apixaban and one involving rivaroxaban, actually did studies where after the patients were on the blood thinner for 6 to 12 months, they were randomized to either stay on that full dose of blood thinner, they went down to a half dose, or the prophylactic dose, or in the apixaban study, placebo. Now these patients, the doctors put these patients on this study only if the doctor wasn't sure whether they should continue with the anticoagulant or not. So people that had a clear reason to stay on the blood thinner weren't necessarily put on this study, and for people that had a clear reason that they could stop the blood thinner were not put on this study. So it was really people where the doctor and the patient were kind of struggling, do you need to stay on it? Do you have persistent risk factors? And so in those people, you can see here that actually the people that stayed on the drug, either the full dose or the lower dose, had a 70% decreased risk in recurrent clot and no difference in bleeding. And this was similarly seen in a rivaroxaban study where patients, again, were on 6 to 12 months of a blood thinner, and then the doctor wasn't sure, should we keep you on or take you off? There were still some risk factors. And they stayed on either the 20 or went down to 10, which is the prophylactic dose, or they were actually given an aspirin. And again, you can see this really significant difference in recurrent clot, again, about 70%, with no difference in the bleeding. So I think what this says is, how do you apply these results to you? Well, I think you have to talk with your provider, and you have to determine, if you can, what was the cause of your blood clot? Do you have persistent risk factors that put you at a high clotting risk? Or do you have risk factors that put you at a high bleeding risk? In which case, even if you are at a high risk of clotting, if your bleeding risk is higher, you may not be on the blood thinner for long. Is it unprovoked? Is it cancer associated? Is it provoked but you have ongoing risk factors, in which case that might push you over to stay on the blood thinner? And then lastly, we did talk about the dose. So in addition to thinking about the type and the duration, how do you monitor it? Well, if you're on warfarin, you have to monitor what's called an INR, and that is done usually by a Coumadin clinic or maybe your primary care doctor. And that can be affected by lots of different drugs and your diet, and you usually meet with a nutritionist to talk about what you can eat and not. The direct oral anticoagulants, there's actually no monitoring that is required for those, which makes them very attractive. The few things that we do look at is making sure that patients' kidney function and liver function tests are okay. And so generally that can be done in people that don't have any issues and are young every 6 months, and in the elderly sometimes every 3 months. And then lastly, education. Well, I think it's really important you understand what drug you're on and why you're on it and for how long, and that you really get your questions answered. And also that you know the side effects of these drugs. So probably the biggest side effect is bleeding, and I always tell my patients, you don't have to live in a bubble, but you got to be careful. Before you do something, say to yourself, if I do this, is there a good chance I could fall and hurt myself? And if the answer is yes, probably shouldn't do it. And really, I educate my patients about the signs and symptoms of recurrent blood clots. So these blood thinners are great, but they're not 100%. People can have blood clots despite taking them. And so knowing if you get a new pain in your leg that is persistent, or it's swollen, or you're short of breath, or you have chest pain that doesn't go away, that you don't ignore those symptoms. So we've set up these two follow-up clinics, and just to share a few things, I always make sure I schedule the follow-up clinic before the patient is discharged and put it in their discharge summary. And I also put a description of what it is in the discharge summary, especially with the PERT patients. I might not necessarily have met them because remember they're in the hospital and it's a group of doctors that are online. It's actually a go-to-meeting similar to this where we discuss it. So I might not necessarily have met the patient in the hospital. So it's important there's actually a summary, a description of it in their summary. And then we always make sure the case manager checks to make sure the insurance is covered, because I certainly don't want somebody scheduled to see me, then it turns out their insurance is not covered here, and then where they're going. So we always make sure that's the case, and if not, we make sure that they're either followed up with a local specialist, and we start with their primary care doctor. And we always contact the patient with letters and phone calls to make sure they know that they're coming and where they're coming. And in our PERT clinic, just to let you know, we've had 2 clinics every month. We've had over 60 clinics with over 350 patients, and it's really been a remarkable experience. I've been an amazing group of people, and actually, you are going to hear one right now. But the other thing I will mention is that one of the things we've been able to do is actually follow these patients for a number of years. And remember that one of the first graphs I showed you which was the mortality rate of patients with massive pulmonary embolism was so high it was 50%. And we recently looked at our first 30 months of patients who presented with massive blood clots, and our mortality rate was down to 25%. Now, that doesn't mean that, yes, this is the best way to do it, but it's really important in doing this that we actually have a way to collect data and figure out how to better treat this problem. So now I have really just the distinct pleasure to welcome my patient, Mark, and he's going to give you his perspective. Mark?
Thank you, Doctor. Good evening. My name is Mark Capadona. It's a pleasure speaking with you tonight. I'm a 50-year-old man that would most likely not be speaking to this group if it were not for Dr. Rosovsky and her follow-up appointment. I'll say that my story starts like many others, but it just does not end the way many others actually have. It's because of the follow-up care provided by Mass General and Dr. Rosovsky. I couldn't tell you how endeared I am to the whole process. Actually going through it, I had no idea I was actually going through the process, but I'm going to tell you my story as I remember it. So Dr. Rosovsky first met me through an emergency room visit on August 6, 2016. I didn't meet Dr. Rosovsky until September 9th at 1 o'clock. So kind of let me explain the way this whole thing took place. On August 6th, I wake up in the morning, hop into the shower, I'm feeling fine. As I'm in the shower, I realize I'm really not feeling fine at all. I'm having major trouble breathing. I say to my wife, we got to take a ride here. I'm having a heart attack. I'm fairly certain that I can't breathe and I'm not feeling well at all. Off we go to the hospital. That's my first of bad decisions. I guess I should have called 911 and had an ambulance pick me up, but we're only 5 minutes from the hospital. We drive over there. I walk in. Wonderful staff at the hospital. Within minutes, they tell me, well, the good news is you're not having a heart attack. You have a pulmonary embolism. My original thought was, oh, this is a good thing. I have no idea what the word pulmonary embolism means at this time. But I'm just happy that I don't have a heart attack. You know what I mean? It says to me, I'm going to be okay. Whatever this pulmonary embolism is, they'll fix it, and away I'll go. And then the emergency staff says, well, we can no longer treat you here. We're going to have to send you to another hospital that can handle this pulmonary embolism. And my 81-year-old mother that happens to be at the hospital at the time yells out from the background, I'd like him to go to Mass General. And this small statement ends up changing the trajectory of my life. Off I go to Mass General in an ambulance. One simple ride in. It was a Saturday morning. I get into to Mass General, and I guess the physician that's attending to the trauma or the emergency room tells me that there's currently a PE team meeting and discussing my case, and he uses the term PE, and I'm thinking to myself, phys ed, I don't know exactly what this gentleman's talking about, but whatever it is, I'm perfectly fine. I'm not sure what they're discussing because I don't know how many patients are here, but there's English and then there's medical English, and regular English isn't necessarily used in the emergency room. So within 20 minutes, this doctor walks back in, says that the trauma team has met, or this PE team has met, and the surgeon's going to come down and meet with me shortly. In walks the surgeon. He tells me that he's going to he'll be working on me. He's just got to get prepped for surgery, and within about a half an hour, we'll be upstairs and getting this blood clot out, and you'll be on your way. Again, at this point, I still don't realize the kind of ramifications of what's happened to me so far. I moved from the emergency room up to ICU, and I don't know if anyone on this call has ever been a patient for surgery at Mass General, but it's simply a remarkable process. They speak to me through the whole procedure, let me know exactly what's going on. No one seems alarmed. We're talking about the Red Sox. One of the nurses is telling me about what the plan is for the weekend. She's going to be serving drinks after 5, so forth and so on. I asked her if I could have one of those as a sedative. She decided not. not to allow me to do that, so that was fine. Doctor finishes up. He says that he's a little bit upset because he was unable to get the complete clot, but they'll break that up over the coming days with medication. I moved to the ICU at Mass General. Care is simply remarkable there. The nurses are explaining everything, make sure that you're comfortable, make sure that you fully understand exactly what's going on. After my 3-day stay at the ICU, I moved down to what I'll call general care. I'm not really sure. It's just one of the floors in the hospital. Mass General is a massive hospital, so this is just kind of one of the floors as I'm recuperating from the surgery. And I found the care to be remarkable. So every morning I meet with the doctor and I would say somewhere between 4 and 8, and I don't know if they're young doctors or exactly what the term is, but these people, they're ambitious young minds, and they want to know everything about my condition. Unfortunately, they're asking the wrong person. So they're asking me about, this, that, and the other, and I'm just looking at the doc. I'm happy to be the patient, but that's about as far as I can take it. And the nice thing that I saw is the interaction between the doctor and these young minds, because they were asking question after question. They get you up, ask you to sit up, and they're taking things. He's asking questions about my case. They're answering questions, some right, some incorrect, but moving forward, I think that the process gets them, here they are, I don't know if they're in medical school, they're out or what have you, but they're simply getting hands-on experience with some of the best in the business. So I feel great about that back and forth. After this whole process, I'm in there for about 3 days, and at this point, it's kind of time for me to leave. And I'm not certain how many people here have been through this, but at that point, you're a little bit taken back. My wife is in, and there's a whole bunch of people checking in, and there's a bunch of protocols at Mass General that need to be followed. But I can tell you that my nurse sits me down, and she starts to talk to me about the pulmonary embolism, what needs to happen, and your mind is wandering about work and family and this and that, and every single word sounds like Charlie Brown's teacher, a little wah, 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 wah. You're not really paying attention. So I don't know if it was just she realized the patient wasn't fully engaged or not, but she took it one step further for me, and on my discharge paper, she highlighted basically the steps that I had to do when I got out of the hospital. So when I got home, it was very easy for me to see exactly what I needed to do. These are your tasks, Mark. Please make sure you follow up. Have a follow-up appointment with Dr. Rosovsky. It's literally highlighted on my sheet that you need to do this, and so forth. So from my standpoint, I couldn't thank the nurse enough, because I think she realized that at that point you have too much going on to realize all the directions that you need to. You now have to go to the pharmacy, follow-up appointments, and all of these other things. It gets thrown at you within about a 15-minute window, 25 different tasks that need to happen, and you're just yesing the nurse to get to death so that you can get out the door. After I get discharged, go home, and I'm feeling better every day, start to walk, and I'm starting to feel like myself again. Actually better than I had in a little while, to be completely honest with you. So still at this point, it's near the end of August, if you will, and I have no idea who Dr. Rosovsky is or what she does. But on my paperwork, it's highlighted. I have an appointment with her at 9 o'clock on September 9th. In this hospital, it's called Yawkey 7B. I remember the nurse saying, make sure you follow up with Dr. Rosovsky. Okay, there's a number right there. I have to simply call. So I call to verify the appointment, and for some reason when I call, it says, welcome to the Mass General Cancer Center. So I hang up, and I must have misdialed. Well, I call right back again. The second time I get the same message, and I'm like, well, I have to assume that they've run out of space in the regular hospital, so Dr. Rosovsky's been kind of annexed to this floor or what have you, because I don't know why I would be going to the cancer center at this point. I talked to her administrator, verify the appointment, and I arrive on September 9th on time. Again, at this point, I know that I've been in ICU at Mass General, so I've had a fairly serious condition. I just didn't realize to the extent it was. So in I walk, and as I walk in, I'm waiting there, and I'm taking a look around, and I realize, geez, this isn't exactly what I thought. I've never been to a cancer center or any type of situation like that before. I've been fairly healthy to that point in my life. But I meet with, I'm going to say it's Dr. Rosovsky's assistant. I'm not exactly sure who this gentleman was or if he was a doctor or not. He meets with me. I introduce myself, and I tell him, my name's Mark Capadona, and I'm from Marlboro. And he says, "Oh my Lord, you're the PE from Marlboro. I'm surprised I'm talking to you right now." Well, now all of a sudden I said to myself, "Wait a minute." He's surprised he's speaking to me. I'm looking at it. So why were you surprised? He said, "Geez, you had a rather large PE." And I said, "Well, you guys have done a great job." And that's when I realized when someone from the medical staff said, "Geez, it's a rather large pulmonary embolism you had. I'm surprised I'm talking to you." I was thinking to myself, whoa, this is a little bit more serious than I had thought originally. At that point, settles me down, sits me down, explains to me what's going on. Dr. Rosovsky's meeting with someone else. She'll be in to see you shortly as soon as she's done. When Dr. Rosovsky walks in, about 10 minutes later, 5 minutes later, I'm greeted with just a giant smile and a high-energy doctor. She asked me if I know why I'm here. I respond, absolutely. My discharge nurse told me that I had a follow-up appointment with you. Well, yes, but not exactly, she says to me. We started an aftercare program to make sure that people, have follow-up after. We want to try to find out what the root cause of your blood clot was, Mark. We're not sure. You didn't have the gene to clot, so we're kind of wondering why you would have clotted in the first place. So in my case, do you mind if I do some what I'll call follow-ups and exploratories just to make sure that everything's fine? We talk back and forth for must have been 15 or 20 minutes. Dr. Rosovsky takes all sorts of copious notes, asks all sorts of questions. It feels like you're sitting down talking with any one of your friends, and it's a great exchange. I don't know if that's her bedside manner, but it's easy to speak to her. So I think you're sharing back and forth, and I think she's finding out things without the patient realizing what she's finding out. She does explain to me, kind of the seriousness of what has happened, what can happen, and what they're looking for. So from after we're done with, I'll say that 15-minute conversation, Dr. Rosovsky and myself, she sits down, does a quick examination on me, asks me if I was be willing to get, have blood taken and some tests done. After that, doctor, not a problem. She said, over time, I'll be back to you shortly after we get these blood tests back. So on Monday, September 12th, I get a call back from Dr. Rosovsky. Now that's high energy, kind of big smile on the phone. I can tell that her voice is a little bit nervous, and I'm like, "Doctor, is everything okay?" She said, "Yeah, everything's going to be fine. We just need you to come in, and I want you to meet a colleague of hers, Dr. Yee, as soon as possible, Mark." So I arranged to meet with them literally on Wednesday that day. I'm talking to her on Monday. On Wednesday, she agrees to meet with me that following Wednesday. I meet with her and Dr. Yee. She explains and kind of tells me, there's some issues with your blood work. From the anemia, we went and took a look, and it appears as though, not actually appears as though Dr. Yee has verified that you have multiple myeloma. She's sorry to have told me this, and they explain what the cancer does and how it affects individuals. At this point, kind of Dr. Rosovsky says, "Mark, I'm going to hand you for treatment to Dr. Yee, and at this point, Dr. Yee will treat you along the way." So I can only tell you that from this PE, I get a cancer diagnosis. That from that point forward, I've only felt better the whole way. The treatment for me was, I don't want to say a non-eventful, but I had no reaction to any of the treatment, and the care could not have been any better. I personally have received 2 rounds of chemo or 24 rounds, and then a stem cell transplant, and then 24 more rounds of chemo. And right now I'm in full remission, and I look forward to keeping it as remission as long as I possibly can. And, I fully believe that without the follow-up clinic, I would have been walking down the street one day, my leg would have snapped, and when I finally got to see Dr. Yee or Dr. Rosovsky, someone would have said, well, it's time to get your paperwork in line because there's nothing we can do at this point. But because they caught it when they did, I'm in a much different situation today, and I'm optimistic that, every day it's a gift, and, I'm looking forward to tomorrow just like you, just like any other patient would look forward to it. So from my experience, and I had no idea what I was experiencing, but the aftercare was more important for me than the actual removal of the PE, because if they hadn't have done that, I'm certain I was careening towards a very bad outcome. So from my standpoint, I can't thank Dr. Rosovsky and Dr. Yee for this follow-up clinic and the work they've done on me and my life. So at this point, that's basically my story, kind of in a nutshell. And I don't know if there are questions, Doctor, or if we open it up at this time, or it goes back to you or Molly.
I just have one closing reflection. Well, first of all, thank you so much for sharing that. And in fact, just to let you all know, when Mark did share that story about being called at the cancer center, we've actually changed the way we tell people now about the clinic, because the cancer center includes both cancer and hematology, both benign and malignant. And so now we actually tell people you're going to be called by the cancer center. So thank you, Mark, because when he shared that, I was a little like, whoo. But to end, so hopefully you have an understanding of what the PE clinic is. And, PE is a common cause of morbidity and mortality. The PERT team is a novel approach to care in very complex patients, and that really the follow-up care is essential. And it doesn't matter who you're, just make sure you are following up with somebody. It doesn't have to be similar to our clinic. And really what you're looking for is, workup and treatment. If you can try to figure out the etiology of the clot, screening for long-term complications, and really knowing what you're taking and why you're taking it and for how long. So I just want to thank everybody. This is my daughter who wrote through, so I'm very proud of her. But thank you very much for your attention. And again, Mark, thank you so much for joining on this. I think your insights are truly invaluable.
Happy to do it. Thank you for having me.
That was just a fantastic talk. Thank you both for being here. We really appreciate it. And we do have some questions. We are approaching the end of the hour, but we'll try to get through as many of them as possible. So Dr. Rosovsky, someone asked, there are so many different kinds of cancers. If someone has an unprovoked clot, why would you only screen for age-related cancers when it could be something else?
Yeah, so that is a really, really good question. And they've actually done a number of studies exactly looking for that. So you're right. And so there's been probably a dozen or so studies looking at that question. In fact, there was one where they took patients and half of them got limited screening and half of them got a PET scan, because there are so many different kinds of cancers. And there was no difference in the mortality rate from the cancers found. So sometimes the screening test did find more cancers, but when you looked at who died from their cancers, whether they were in the limited screening or the extensive screening, that there was no difference. So whoever asked this question, you are correct. There are other cancers, but based on the number of studies that have actually looked at these two kind of different scenarios, people just doing the limited versus extensive, because there's no difference in mortality, it is currently not recommended. But I cannot emphasize enough that if you do have any abnormalities in your, how you're feeling, or in your physical exam, or like Mark in his blood work, that you do not ignore that.
Great. And then similarly, another patient asked, how does cancer cause a PE? And they also wanted to know if they can fly if they've had a PE but they're on an anticoagulant. Okay.
So that's also a really good question. The pathophysiology of how tumors provoke a blood clot is lots of different mechanisms, and a few of them are that they kind of release a tissue factor, a procoagulant, which kind of stimulates the clotting system. And there's also different cytokines that get revved up. And so there's lots of different mechanisms that kind of turn on that clotting system. And so that there's a lot of really interesting research being done on that, and even how that same mechanism might be related to how actually tumors progress. And in terms of the flying, so if somebody has had an acute blood clot, like Mark, let's say Mark, you know, I saw him a week later and he said, hey, I want to fly to Europe, I would say, no, probably not. I generally don't have my patients fly when they've had an acute blood clot, because I think that they need to recover a little bit. I want to make sure that they can actually walk up a flight of stairs and not have shortness of breath, especially if they have blood clot in their legs too. So I do not really advocate for flying soon after an acute blood clot. But if it's been, you know, it's been a while and you've been on a blood thinner and you're kind of back to your baseline, I think that there's really no issue as long as you're on your blood thinner. And what I tell people is make sure they get up and walk around if they can every hour, make sure they drink a lot of water, try to get an aisle seat, you wear compression stockings, do little exercises at your chair if you can't get up. I tell people to try to refrain from drinking alcohol in the airplane because that can dehydrate you, and to refrain from taking one of those sleeping pills because that's kind of immobility at its finest. If you're someone that has had cancer and clotting, you're probably on your blood thinner. But if you're someone that's had a clot that was, let's say, provoked by something else, and you're going to go on a long trip, you might want to be put on a prophylactic blood thinner. And so I would just talk with your doctor about that.
Very interesting. And then another patient in 2009 had a PE, and they never found out what caused it. They're now on Eliquis, and they wanted to know if they'll ever be able to stop taking their blood thinner if they're able to exercise more or get down to an optimum weight. Would this make a difference, or is there anything that they can do that would make a difference?
Yeah, so that's a really good question. And again, that graph that I showed you in patients that have idiopathic or unprovoked blood clots, so the risk of, there's been several studies looking at this. Actually, Dr. Goldhaber did one of the studies where they actually would have people do, 6 to 12 months of blood thinner, and then half of them were taken off and half of them were kept on. And the risk of having a blood clot within 2 years of stopping your blood thinner, if it's an unprovoked clot, can be as high as 25% and even higher over the next subsequent 5 and 10 years. So when thinking about whether or not you should stay on the blood thinner or not, it really is kind of weighing the risks and benefits. Kind of what's your risk of having a recurrent blood clot if we stop your blood thinner versus your risk of bleeding if we keep you on it. Majority of people that have unprovoked blood clots, I'm more concerned about their recurrent risk. And there's all these prediction models that you can throw in the numbers and figure out exactly what it is. But in general, it's about 25% over 2 years. It's much higher in men. It's much higher in younger people. In terms of the weight, that's a really good question. If you are overweight, it does increase your risk of having another blood clot. And so I would encourage you to absolutely lose weight. And the question is, could you lose enough weight that you could go off the blood thinner? Again, I think that's a conversation to have with your doctor. But if it's been an unprovoked blood clot and it was fairly significant, I would be very hesitant to stop it. But I think losing the weight can definitely decrease your risk of recurrent clots. And also, if you're on the Eliquis, there is that data that I showed that you can even talk to your doctor about going down to the lower dose, that 2.5, and that those studies just came out recently.
Interesting. And we actually did get a very similar question about a patient who, 2 years ago had a right calf DVT and was put on Lovenox and then Coumadin. And he's in the therapeutic range. He lost 80 pounds, and it seems as though his blood clot has resolved. And his hematologist offered to follow him on aspirin, but he's kind of concerned about that because he lives a very active lifestyle. But he's worried about, being off of the medication. Do you have any thoughts for him?
Oh, sorry. And this was a provoked or an unprovoked blood clot?
I'm not sure. It doesn't say specifically, but he was overweight at the time and he lost a lot of weight. And he says that, it shows that the blood clot's almost gone, and it's recanalized, which means that I believe that everything's kind of seems as though it's healing.
Yeah.
So it was the hematologist who wanted to
Okay.
put him on aspirin?
On aspirin, yeah. So the two studies that I showed you, which were, one was compared with a lower dose of rivaroxaban with aspirin, and then the apixaban was with placebo. So we do know that aspirin, instead of nothing in patients with unprovoked blood clots, will decrease the recurrent risk by about 30%. When people have a distal blood clot, the current recommendation is if you have a distal blood clot, even if it's unprovoked and you don't have ongoing risk factors that seem to provoke a blood clot, typically we do 3 months. But if you have ongoing risk factors, then I would keep people on a blood thinner. I think if your doctor felt like your only risk factor was the weight, the ongoing risk factor, and that has resolved, then it's certainly reasonable to talk about stopping it. And then there is some good data. Again, if it was an unprovoked blood clot, there is good data that does suggest that the aspirin can decrease your risk of recurrent clot.
Wonderful, thank you. And then another patient wanted to know why blood thinners seem to cause fatigue, and specifically she's been on Coumadin and experienced that.
Yeah. You know what? I don't know the answer to that question. I have some of my patients say that. Sometimes I have patients that might have certain symptoms on one of the blood thinners, and it's hard to know whether or not it's due to the blood thinner or whether or not it's due to something else. And so sometimes we'll actually switch to a different one and see if it goes away. And so it's really hard to know. Is it the Coumadin or was it actually residual effects from the blood clots? It's very hard to know and tease that out.
Thank you. And then another person asked about something that would be similar to a telestroke service. Have you ever thought of developing a tele-PE response team for acute PE?
Yes. Oh my God. So yes. Actually, the PERT, when we started the PERT team, we've actually started a national PERT consortium, and we have a 501c3, so we're a nonprofit, and we have about 100 and I think over 100 institutions around the country, actually around the world. And we have different committees, and actually I'm heavily involved in the education committee. And one of our initiatives that we just started was to think about doing a telepert for the exact reason of, what if you're a community hospital and you just don't have the resources that, let's say, Mass General or the Brigham has, how can you get that experience? And in fact, we've had at our PERT, we've had people from outside the state call our PERT. We actually had an ER doctor from another state who had heard one of our lectures call our PERT team and say, hey, I have this patient. And we actually had a PERT conference call, and the patient herself got on the call. We often have patients join the call, and we decided that she would best be served by actually coming to Mass General. So she was metaphyled to our hospital and underwent care. So we actually do get calls from people outside the state, and definitely from around community hospitals. But in answer to your question, we are very interested and in the early stages of figuring out how to do that, and we're calling it telepert. So that's a great question, and yes, we're really excited about that.
Wonderful, that sounds exciting. And then we have just a few last questions. Are we getting close to having an antidote for Eliquis?
Yeah, so there is one that's in clinical trial right now, and Nexinet, and it's in a phase 3. And so I always say to my patients, I'm hoping in the next 6 to 12 months we're gonna have that. It's still in phase 3 trials. We actually have it open here at Mass General, and actually the Brigham has it open there too. I don't know the time frame, but there is an ongoing study right now, which will hopefully we'll get an answer to, and hopefully get that approved. So I tell people, in terms of the bleeding risk, is just really try to be careful. And I mean, look, you always are at risk of doing something, but don't make decisions where you're actually putting yourself at a risk of getting hurt. And then I tell people to, if they do, to just try to seek medical attention. I also tell people to get medical alert bracelets if they're on one of these new drugs, mostly because there's no blood test that would tell people you're on it, unlike warfarin, where you can actually check an INR and that they're on it. There's not a blood test for these new agents. So I tell people if you're going to be on the new agent, you're going to be on it for a long period of time to get a medical alert bracelet. And you can Google medical alert bracelets or go to your local pharmacy and pretty much have your name, what kind of blood clot you had, so pulmonary embolus, and then what kind of medication you're on.
That's great advice. And then we had another patient ask if there are any doctors in Canada that are using PERT.
Oh, yeah, so we do have some PERT teams in Hamilton. So Philip Wells, who is actually the Wells criteria for trying to figure out if somebody has a blood clot, he's very involved and has, I don't know if they call it PERT, but they're very similar in terms of what they're doing up there. And so let me try to think. I can find out and I can give that to you, Molly, and maybe you can reach out to that person. I can get other names if they want to specifically tell you where in Canada they live, and then I can find out where they might be. So we definitely do have them. So if you can find out from that person, whoever that caller is, if they can email you the actual place where they live, and then I'll find that out for you.
Sure, and whoever the person who was interested in that, Rose, if you're on the line, if you want to send an email directly to info@natfonline.org, it's right on the screen on Dr. Rosovsky's slide. We can definitely get that information for you. And then we just have two more questions that I'm going to take, and then I'm afraid we're going to have to end the call just because we are a little bit over our time. Someone asked if they had a PE 3 months after a radical nephrectomy for a malignancy, would there be an association between those?
Oh, yeah. Sorry, so for a malignancy, did you say?
It's a radical nephrectomy malignancy, and the PE occurred 3 months after.
Oh, 3 months after
Yep.
That seems a little long. So probably not related to the surgery. So if you have surgery and you have a PE within a few weeks of the surgery, but if it's been 3 months, probably not related to surgery, but certainly could be related to the cancer. So we think of cancer-associated blood clots if they occur within 6 months of the cancer. So it certainly could have been related to that. And again, as Mark said, I sit down with my patients and really take a really good history to find out what other risk factors might have been present, but certainly we know cancer is one of the biggest risk factors, and if it's been within 6 months, we often will think that it's due to that. But probably not the surgery if it's been 6 months, 3 months.
Okay. And then our last question is, if you've had an unprovoked PE and were treated successfully with an ECOS catheter, is it advisable to get Uflex shots for arthritis in the knee? Or I'm sorry, Uflex shots.
I don't know what a Uflex shot is. Uflex?
All right. It's EUFLEXXA.
EUFLEX. EUFLEX. Sorry, I don't know what that is. EUFLEX?
XXA. So it's 2 X's and then an A.
Efluxa. It is for osteoarthritis. It's a sodium. So I would say that when I have patients on a blood thinner that need any kind of procedure, I generally would call the person who's doing the procedure, and I say to them, is this a procedure that is considered a high bleeding risk? And if it is, then I will generally have the patient hold, depending on what their thrombotic risk is, and how urgent the procedure is needed. But if there's a chance that there's a bleeding risk with the procedure, then I generally do have them hold their medication. And again, it depends on how long I hold it, depends on which medication they're on, what their kidney function is, what the procedure is. So I would have your doctor call who's ever doing it to find out exactly what the procedure is and what the possible bleeding risk is, because there's a lot of procedures that can be done where you don't have to hold it, and then there's certainly ones that you do.
Very interesting. Well, thank you so much for your time, and if anyone on the line has more questions that have not been answered, I'd ask you to please email them to info@natfonline.org, and we'll work to get as many questions as possible answered. And thank you everyone so much for calling, and Dr. Rosovsky, this was such a wonderful presentation. We really appreciate your time.
Oh, thank you. Thank you so much for So Molly is amazing. I'm sure the people that are on the phone call know this, but she is such an advocate for all of you. It really is incredible to work with her. So I really appreciate you asking me to do this, and it's been such a pleasure to work with you, really.
Oh, thank you. And I'd also like to thank Mark for calling. Sharing your story is always so helpful for other patients.
Happy to do it, Molly, anytime. Please let me know if you need it again.